So here we are in January, our new year. Happy New Year to all of you if I haven't seen you yet. Our table captains hopefully are tallying all the funds. Are you good, David? Good? Okay. One thing I'd like to do, I know we all, kind of gather and you look for your friends and you sit down and maybe you know everybody at your table and you've known them for a million years. But just in case, look around your table, introduce yourself to somebody who you don't know. Introduce the whole table around unless you're already familiar with everybody. Say hello to somebody, to a strange face. All right, good morning again. So now that you've met all these strangers and you're good friends, do we have any guests here today other than our speaker? We have a guest. Could you stand and just tell us in a loud voice who you are? Tell us a little bit about yourself. No? Okay.
Hello, Sid Sharp, Dave Nyhorst.
Okay, do you live in this area, Sid, or?
It's not far, Cherry Hill.
Cherry Hill, that's very close. Welcome. Anybody else, a new member that hasn't introduced themselves, or another guest? No? Not today. Okay. Rob Levine, would you like to come up and present badges to anyone who hasn't received theirs yet, new members from the last month or two?
Our newest member is Andy Savicki.
Yes.
And the check cleared, so please come up. Andy, can you just tell us just a little bit about yourself?
Sure. Thank you. Thank you for...
Here you go, Andy.
Is that... Oh, okay. The truth. Thank you very much for allowing me to join
Scott, he works alone.
Organization. Just a little bit about myself. I live in Glassboro, New Jersey. I've been married for 48 years to the same woman. 4 children, 2 grandchildren. I'm a licensed clinical psychologist, and I've done my graduate work at the University of Pennsylvania. I served with Dr. Yorker in the 108th Medical Group as a psychologist and Inspector General.
Nice.
Then I went to the 177th and continued as the Wing Director of Psychological Health. Thank you very much.
Thank you. Thank you. Thanks, Ed.
So I wanted to take a minute. Some of our members arrived here early today and helped with Super Sunday. I'd like to recognize those under the direction of Bob Greenberg. Whoever was down with Bob and set up for Super Sunday, could you just stand? And thank you. I wanted to make you all aware. We have 2 members that are currently at Powerback. I think we probably should have a suite there, the South Jersey Men's Club suite. But anyway, Barry Adler has been there for about 2 weeks. He's due to leave, I believe, on Wednesday. And Rich Dutkin is there, and we've talked about Rich before. He was in Lionsgate for a while. Now he's at Powerback, and hopefully he'll be getting out shortly. So if you have a chance and you're either visiting someone else at Powerback or go visit them at Powerback, they're both there. I saw them both yesterday, and they're in good spirits. By the way, Powerback is just a little bit south of Virtua on the same side. That's the Route 73 Powerback. I know there's another one in Moorestown, but they're both at Route 73 in Voorhees. Steve Barsky, I wanted to thank you for taking over Barry Adler's 50-50 duties. Thank you.
How about the guys that make breakfast?
And the guys that made breakfast. You want to stand up, guys who made breakfast faithfully every week? A special thanks to Jay Sternchos, who, with his new knee, is just better than ever in there. I think that's it. We're under a little bit of time pressure today. We want to be out of here by 11. They've got a lot of things going on. I didn't know about it till this morning. They told me they'd like us to be out by 11. I don't know, is there an investment club scheduled for today or no?
It's a birthday party.
No, but I'm wondering if are we doing an investment club today or not?
If the card shows up, you can do your best.
If we need to do an investment club, we can kind of do it on one side. They just need to set this up for another affair.
Ed, do you want to recognize Mike Thorwell again?
I was going to do that after breakfast. Yes. Anyway, those people who need a little extra time or a little extra help with breakfast, don't move yet. After the motzi, please give them an extra minute or two to get started at the breakfast tables. We have an honoree. We have an honoree here today, and we'll tell you a little bit more about it after breakfast. But Mike, would you like to lead us as our honoree today? And we'll tell you. Well, I think most of you know because you've seen the email. But in any case, Mike, would you lead us in the motzi?
You ready?
We're ready.
Baruch.
Adonai Eloheinu melech haolam hamotzi lechem min haaretz. Okay. Good morning again, gentlemen. I left on the table this morning 8 copies of a pledge. And I was at a meeting this week. I don't know if you were watching the news. I think it made just about every news channel. All the major stations were here. I guess it was Thursday. There were a couple of meetings on anti-Semitism and security also. And one of the things was the signing of this pledge. And I'll let you read it to yourselves. There's 8 of them on the table. If you agree with it, and I hope you do, if you would sign it and leave it on the table, I will collect them and pass them on to the JCRC. That's where they came from. And I think it's very important that we all recognize that the incidents are way up. I don't have to tell you. You read the newspapers and so forth, and we can participate. And make sure that we're not guilty or that our friends are not guilty of speech that's hateful, not just to Jews, but to any religion or race. Thank you. Regarding security, while we're on that subject, I think you all know the JCC has hired a security consultant, Doran Harwitz, and they are in the middle of assessing the building, assessing the area. I mean, it's a big job, obviously. I asked him specifically, I said, you know, we've got breakfast here every Sunday, once a month. You know, we have no idea if there is an incident in the building, what we're going to hear, what we should be doing, so forth and so on. It's a concern to us. And he said, it'll be a couple more weeks. We've already assessed this room and what we need to do. And of course, they're assessing the building and the surrounding area. And, you know, it's a big job, obviously. It's not done in a week or 2. But anyway, he said within the next few weeks, they will have a plan and they will discuss with us what we should be doing here when we're in the building. And obviously, we're all here for other reasons, not just for our breakfast. So I assume there will be some type of a master plan which everyone will be made aware of. Not necessarily of all the details because they don't want to disclose all the details, but in any case, it is in the works. I think you're all aware that one of our members who has been the driving force between the law enforcement for the law enforcement breakfast for, I think they said 25 years. I'm not that old, so I don't remember. That it's been 25 years. Has it been, Mike? 25 years?
First one was in 96.
Okay, 25 years. And of course, we have one coming up April April what, Mike? Mike, April 21st. So be aware that one's coming up. But in any case, the Burlington County Chiefs of Police, and I don't know exactly how many there are, but had their annual installation of executives, officers, and so forth on Friday night at the Madison in Riverside. And they recognize someone who has been helpful to law enforcement each year. And we received a call from Scott Perlman, who's the chief of police, and I think was the chief officer, president, I guess, of the Burlington County Chiefs this year. And there is an award called the Dreby President's Award that they award to someone. And I'd like to read to you the citation. Presented 2020 Dreby President's Award, presented to Michael Perloff for services set forth in the following citation. For outstanding achievement and loyal dedication to duty as a member of the South Jersey Men's Club, Mr. Perloff has been an advocate for law enforcement throughout southern New Jersey. Mr. Perloff is responsible for the implementation of the Toys for Tears program. Mr. Perloff has been instrumental in the Law Enforcement Appreciation Breakfast that is held annually to honor exceptional members of the Southern New Jersey law enforcement community. Mr. Perloff is one of the founders of the Camden County Corporate Watch, which has brought together private business and law enforcement throughout Southern New Jersey. Mr. Mike Perloff's exceptional professional ability and loyal dedication to duty reflects great credit upon himself and were in keeping with the highest traditions of the Burlington County Police Chiefs Association. William T. Eliason, 2019 President. Michael. And believe it or not, Mike got up and accepted the award, and in 10 seconds he was seated again, which surprised me, but I think you did a wonderful job, Mike. Would you like to say a few words?
I finally found out what it was like to be the subject of a sting operation. I knew nothing about this. Truly, the guy's up there speaking and reading these things without my name, and I said, wait a minute, that's got to be me. But they do appreciate us, not just me. I mean, I'm just one guy. But I know a lot of these people because over the years I start to talk to the different police chiefs and prosecutors and state police and on and on and on, and FBI and all that. And they know that the Jewish community is not just us and they. They know us as people and individuals, and that's the purpose of everything we do with this. So, and I urge you to try to attend the law breakfast that we'll be doing on Tuesday, April 21st. I ask one thing. Anybody who's ever been to it or has worked and volunteered, please raise your hand. Well done. That's me. Thank you very much.
And along with the citation that we have here is another citation that says, Burlington County Police Chiefs Association Chief Richard Dreby President's Award for outstanding dedication and service to the Burlington County Chiefs of Police. So they did a really nice job. Michael?
One thing, the Zionist Organization of America is one group. There is about a gazillion Jewish groups in the United States. But the World Zionist Congress is held periodically. They're the ones that in the 1880s, they came up with the idea of Israel, Theodor Herzl. And they meet every so many years and decide how to allocate for Jewish causes billions and billions and billions of dollars. How do they get people who go there? Well, the last one, I was one of the representatives from the United States. The next one, the elections are happening now, and through February, and I think part of March. If you look up World Zionist Organization elections, you can vote. They do charge $7.50, less than this breakfast, to meet the cost of doing this worldwide. I urge you to go online, look it up, and look through the different platforms of the different organizations. It covers everything from crazy left to crazy right and in the middle. Pick one and vote. Thank you.
Vote on slate 6. That's the conservative movement. And there are 4 people from this community who are on that slate. So think about that. That's the conservative movement.
Okay.
Right.
So the other day when I attended this meeting, one of the things that came up was the JCRC, our local JCRC, bought 1,000 of these books. It's a book called How to Fight Anti-Semitism. It's Barry Weiss. I have 5 of them. If you'd like to read it, there's no charge. If you would take it, read it, bring it back for the next meeting, we'll make it available to the next 5 people who'd like to read them. If you'd like to contribute to the cost of them, $5 will contribute to the cost of them. You don't have to pay it when you come back, or give us whatever you feel you want to give for the book. But take it home, read it, let your wife read it, but if you would, please bring it back for the next meeting. I don't know, I think it's available on Amazon also, but obviously this is a better price than Amazon. I think that's it. David? Anybody else? I'm sorry. Oh, Rich, I'm sorry. You wanted to mention Yom HaShoah.
Okay, sort of in the same vein, put on your calendars, the Yom HaShoah observance this year will be on Monday, April 20th. It's going to be at Congregation Bethel, right by Main Street. And of course, the Men's Club is fully supportive of this. South Jersey Men's Club gives out the yellow Yom HaShoah candles. We'll be doing that again. The candles already have been ordered, and we do take donations to support the candles. A box of candles is $72. You can donate a box, half a box, quarter box, whatever you have. We'll be gladly take that, and any money that we generate through this, it gets donated straight to the Holocaust Education Committee, the Rob Goodwin Holocaust Museum and Education Center. So again, that's Monday, April 20th at 7 o'clock. We like guys to be there around 5 so we can get things set up, and it'll be at Bethel. Another thing I want to mention about how to fight anti-Semitism, this is a very important year. In 1940, the first mass transports of Jews were arriving at Auschwitz. And tomorrow is the 75th anniversary of the liberation of Auschwitz. There are major conferences going on. Heads of state have arrived from Jerusalem. Heads of state will be arriving at Auschwitz tomorrow. So if you go online, it's just a very important thing to remember, and we can't forget, and we got to keep fighting. So again, it was the 75th anniversary of the liberation of Auschwitz. And again, Yom HaShoah again is on April 20th, on Monday at Congregation Bethel. Thank you.
Thanks, Rich. David Schwartz, would you like to introduce our speaker today?
In the last week or so, the Men's Club has participated in 2 functions, probably more, some that I'm not aware of. Mike Perloff and Nelson and others put together 30-some odd pieces of outdoor porch furniture through the JFCS for the Weinberg Commons down the street here. And Mike was nice enough to spearhead the activity. I think he was there 4 different days assembling these pieces of furniture. Very durable white plastic rockers and tables and benches. So I'm sorry for not mentioning all the names of the guys who were there. Thank you for all who did that. The other function was called Mitzvah Day last Sunday, the 19th, where we were asked by the JFCS to provide a table, an activity, and money, of course. For Mitzvah Day, which was only 2 hours, the thrust of the program was to provide 1,000 what they called chemo bags to the Cooper medical system for cancer. People who get chemo, while they're getting it, they are given one of these little bags, and they have treats in them. As far as I know, breakfast bars and other items, and the name of the JFCS is on it. And in 2 hours, with donated food items from many organizations in the area, they put together 1,000 bags for Cooper. And some of the other participants were synagogues and other organizations who help raise funds, donate items to the cause. So we had what was called a mezuzah day. The organization bought 75 mezuzahs that were really cute. They came from New York. They were about 7.5 inches high by 2 inches wide. Had a little slot in the back for the Shema, the little scroll, and we provided a table and a couple chairs, the mezuzahs, markers, and stickers, hoping that kids would stop by and color a mezuzah. And we were very successful. It turned out to be a marvelous program. We were exhausted by the time the 2 hours were up. We were playing Pop Zadie for the 2 hours, and the kids loved it. It was just one after another. We had them lined up like 7, 8 at a time, and I think there will be, if there aren't already pictures on Facebook, there will be. So thanks for the guys who participated in that function. Eddie Silver, who's not here, Ed Stein, and others. I'm sorry, I can't remember the names. Today's, as you know, I try to get 1 or 2 men's health topics a year programs, and this is one of them. And I wish I could take credit for it, but I can't, because a lovely young woman who's here this morning, Chelsea Beatty from Boston Scientific, contacted me on her own a few months ago and offered to provide a speaker to our men's club. And I was reluctant in the beginning, I still don't know why. In any event, I'm glad that we have moved on to today. Chelsea, thank you very much for your participation in your organization. Dr. Gore is here from and he will give you I couldn't pronounce these words that pertain to him, so I've asked him to do a short bio. Dr. Gore is with the Cooper University Healthcare System to talk about men's health topics. And we also have one of our own members, Earl Nagelberg, and Ray from Gibbsboro, Pennsylvania, Gibbsboro, New Jersey, who have experienced some health issues in the past, so I'll let them explain that. So please welcome Dr. Gore.
All right, well, thank you very much, David, for Mike. Is that better? All right, great.
Old guys can't hear.
I hear you. No problem. I probably can't help you a lot with that, but thank you, David, for working with Chelsea and I and Cooper to help arrange this. It's really an honor to be here. I pass by this building every day and have never really entered, and I see the input and output of people, and there's always such a vibrant population here and lots of people coming in and out from all different types of communities within the region, and it's really nice to be here. A couple other things. Dr. Yorker is here, and when I walked in, he was smiling bright looking at me, and he's actually an attending physician of mine from back when I was a trainee, so he and I have known each other for quite some time, so it's always nice to have a familiar face here. Although he introduced me as Dr. Gore, the amount of accomplishments and stories that are in this room and things that I can learn from you are much more than you can learn from me, so please, if you address me, call me Ron, and I would appreciate that. So again, thank you for the opportunity. The stuff we're going to talk about today can be a little bit challenging to discuss. I think this is a perfect group for it because I think everyone here knows each other a little bit better than sometimes when we do this in an area where no one really knows anyone, where they're not really comfortable talking about this type of stuff. But at the end of the day, these are topics that we all need to discuss because when we're all home alone or driving in the car or in the bathroom, you're thinking about it. it bothers you, it affects you, it affects your family, and it's stuff we need to talk about and have you in to talk to different individuals about so we can get you and help you with your quality of life. So I want to leave a lot of time for questions because I think this group is going to have a fair number of questions because I think everyone is comfortable with one another here. So if I am rushing at all through certain things and you want me to repeat or speak up or slow down, please let me know. All right? I'll move this over here. All right, so just a little plug for Cooper since I'm here, right? So this gentleman is Dr. Seftel. Some of you may know him, may know of his name, but he, helped hire me and has been a great mentor and friend to me. And this is me. We talked about each other. Dr. Yorker was at Einstein with me as well, and I did some extra training in Minneapolis to focus on some of the stuff we'll talk about today. We have Dr. Bernhardt, who can take care of pretty much any stone problem anyone can possibly have, no matter how complex it is. Dr. Canto. We have probably the best urologic cancer surgeons in the region by far. If anyone I care about needs to have any type of urologic cancer operation, I undoubtedly will send them to Cooper, even if I didn't work here. We have a whole army of people to help us. Our building is beautiful and new over the past 5 to 10 years. We have an awesome cancer center, partnered with the best cancer center in the country, and a medical school that I am part of teaching. We have students, we have residents, and educating the future of urology. Our footprint is expanding and hopefully will continue to expand into areas all over the place to come to you rather than you coming to us. So the first part of the talk, and probably more of the talk, will be spent on dealing with erectile dysfunction, and then at the end we'll talk about some issues with urinary leakage that can happen after prostate cancer therapy. All right? So what is erectile dysfunction? Who has it? What causes it? Well, it's the persistent inability to achieve or maintain an erection firm enough to have sexual activity of whatever type you want, okay? Now, the thing to keep in mind is more than half of men over the age of 40. I see 20-year-olds, I see 30-year-olds, I see 40-year-olds, 50, and so on, who have erectile dysfunction. It's very common for men in their 30s, 40s to come to me, and they're very embarrassed to talk about it because they feel so young, right? But it takes comfort in knowing that pretty much everyone at a good majority of men over the age of 50 will certainly have some degree of an issue. We'll talk about the erection process very briefly. There's a variety of factors that have to happen. First, you have to have arousal. Nerves need to sense the arousal, which activates a cascade of a variety of enzymes that result in the blood vessels in the penis actually growing to allow blood to come in. And then conversely, there's an outflow, almost like a stopcock, if you will, that will keep the blood in the penis to help you maintain the erection. So sometimes you can have an issue on the nerve level, you can have an issue on the inflow level, not enough blood is coming in, or you can have an issue on the outflow level where things are coming in, but it's also leaking out, and so you're not able to maintain the erection. So we customize your treatment based off of what your underlying issue is. A variety of issues, as we said, can lead to this. It can be simply a vascular issue, diabetes, medications, and when you come in, we go through all of your history to kind of figure out, well, why is it that you are having this issue, so we can customize the treatment plan for you. Now, in terms of quality of life, erectile dysfunction is something we may make light of as we get older. We may, joke about it with our friends about how we used to be able to do things, or, I hear all types of these jokes, and that's fine. That's a great new way of coping with things, but ultimately, it has a major impact on your quality of life in terms of overall emotional health, mental health. It leads to increased rates of depression, and improving it can help you with those things, right? It can help you with your overall vitality, your cardiovascular health. It's tied to improvements in your cardiovascular function once you have erectile restoration and regain some of your sexual function. We'll talk briefly about diabetes. It's a very common issue to have in my community as an Indian American. No matter what I do, if I stay in the same shape I am now, statistically and genetically, there's a good chance that I, in the future, will develop type 2 diabetes despite trying very hard to avoid it. A lot of it can be genetic and we can't control it. So, if we are diabetic, one, it's a huge population of men who have diabetes. 1 in 2 men who have diabetes will have some degree of sexual dysfunction. Obviously, this will depend to some degree on your degree of diabetes and how controlled or uncontrolled it is. But in general, it's very common in gentlemen who have diabetes. Issues that can impact this are, one, how long you've had it, how old you are, what type of complications you've had. Even if you had a period where it was highly uncontrolled for a few years, it can have irreversible impact on your nerves. And even if you get into better glycemic control and your blood sugars are better and you're in a good place, some of those changes can be irreversible and you may have permanent erectile dysfunction from that. Diabetes at the nerve level will impact the ability for the nerves to stimulate the cascade to allow your body to send the hormones to the penis to allow the blood vessels to open up. So even if the blood flow is great, if you don't have that stimulus based off the nerves due to a diabetic complication, it's still going to be very hard to have a meaningful erection. Erectile dysfunction and heart disease. There are probably physicians in here who are much better versed at heart disease and cardiovascular health than I am, so feel free to chime in if you have any comments. But in general, symptoms of heart disease will develop, it can all develop after erectile dysfunction. The way to think about that is, if you have poor blood flow in your penis where the blood vessels are a lot smaller than those in your heart, it may predict that in the future you may have poor blood flow to vessels in your heart. So what do I do and what do many individuals who treat erectile dysfunction commonly, what do we do? Well, if you're younger, healthy otherwise, don't have major issues, if you come to me and say, man, I've been noticing that my erections aren't as strong as they used to be, they're not maintaining long enough, before we go down a treatment path, I'll plug you in with a cardiologist to make sure that everything's okay. Now, more often than not, it is okay, but we've all heard stories of, man, he was 55 and looked like the picture of health, and next thing you know, they had a heart attack and passed away. And so the last thing I ever want to do is help someone with their erections and then they end up exerting themselves and having a heart attack and passing away. That would not be an ideal scenario, and so that's what we'll do. So this has been an increasingly focused topic of study because we know that we're able to find and prevent some cardiac events from happening when you come in for your urologic evaluation. So obviously the stuff that you can do to help you for your heart health can definitely help you with your vascular health, to help you with your function, whether it's weight loss, smoking cessation, reducing stress. Obviously coming to a place like this where you can be amongst your peers, which is stress reduction. You can stay active in the gym and in the pool and in classes. These are all good for your overall health. So coming to a place like this can certainly be helpful for individuals, as I'm sure you're all aware of. And a very important one I want to talk about today is the impact of prostate cancer on erectile function. Prostate cancer is extremely common. There's over 70,000 episodes or individuals diagnosed a year, and that number will continue to rise. And we're doing better each year about selecting the appropriate people to treat, because we know that treatment comes with a lot of side effects. And so finding the right people to treat is how we can help prevent unnecessary complications. But once you're already at the point where you've had the diagnosis and you truly have a cancer that requires treatment, there can be issues, but as anyone comes in, no matter how bad a function they have, I promise you I can help you, make you feel better. I can get you to where you need to be. We'll talk about how we can get that for you, though. So what happens in prostate cancer surgery? Well, this is the prostate gland. The prostate gland sits around the junction between the bladder and the urethra, which is the tube that you urinate from, and it sort of sits around the tube like a donut. It was designed interestingly because its major function, if you're unaware, is basically to provide a couple proteins to your seminal fluid to allow it to liquefy in the future, which does help for conception, and so it is a very important enzyme. But what it really does is it annoys men and turns into cancer, right? So it turns into cancer in the sense that if a man lives long enough, more likely than not, they will develop some degree of prostate cancer. It may not be the cause of your death, but if you live long enough, there's a good chance that prostate cancer will develop if you look for it. The other thing that can happen is it can grow into your urethra, right? And it sort of sits around the urethra tube like a life preserver and squeezes and squeezes and squeezes, and then you have to push and strain and wake up at night and go urgently and keep a empty bottle of Mountain Dew in the car like a lot of my patients will have to do, and do something called toilet tracking. When you go to Walmart, you know where all the bathrooms are around the corner, and you plan your produce sort of delivery until you can end up near the bathroom. And I'm sure this is something that has impacted you. The focus of this talk will be more about, in the future, about leakage. Will be less about the frequency and urgency and more about the prostate cancer stuff, but happy to answer any questions about that as well. The issue about prostate cancer surgery is that the nerves that help you with your erections are located very close to the prostate. And despite having technology to help us move those nerves away, inadvertently or inevitably, there still will be some compromise to your erectile function. Now we talk about erectile restoration. So there are a variety of ways we can improve your function and help you with you and your partner's quality of life. It just depends on ultimately what your goals are, what your overall health is, and how you feel about some of the interventions. So we'll talk about medications, injections, implants, vacuum devices, and suppositories briefly, and then if you have any questions, if you want to stop me, you can ask. If you want to wait till the end, that's fine too. Up till now, any questions I can get into?
Just one. How can a patient tell the difference between cancer and benign prostatic hypertrophy?
So that's the great question, and the question is, if you're having issues with either erections or urinating, how do you know if it's prostate cancer or just your prostate's growing? Well, more often than not, it's just your prostate growing. If you have a urinary issue or symptoms because of a prostate cancer, it's most likely a highly advanced prostate cancer, and your blood work and your exam should reflect that. But ultimately, a urologist or a physician would be able to very easily tell you that. If you have a normal exam and a PSA is within normal ranges for your age and you have symptoms, it's most likely just a benign process in your prostate. But if you have a sky-high PSA and an abnormal exam and you're having these symptoms, then we'll be able to tell you if it's cancer-related. So, what we call PDE5 inhibitors, or Viagra, sildenafil, Cialis, tadalafil. I'm sure everybody is familiar with these medications, seen it on TV, friends that have taken it. And what do? Well, these are medications that actually help prevent an enzyme that breaks down the stuff, if you will, that promotes you from having an erection. All right? So it kind of just keeps the wheels turning for you and helps you maintain and achieve the erection. Okay? You still need to have arousal during this. If you take a medication and you're, in an unarousable situation, you're not going to just randomly get an erection unless it's a super high dose and you already have good function. So that's why we tell you that depending on the medication, you have to take it 30 minutes to an hour before you have sexual activity, or for tadalafil, you can take it within 36 hours. All right? Interestingly enough, this medication was initially designed for pediatric pulmonary hypertension, which is high blood pressure in the lungs, and it actually still is used for that. And they found this to be a side effect, if you will, of the medication. And then obviously, a drug company's eyes lit up and dollar signs were flashed, and several $1 trillion later, we have all these medications that have actually helped a fair number of people. So I suppose it was worth it. One question that always will come up is insurance coverage, and a lot of insurances don't cover it. but we've partnered with a compounding pharmacy that we can get it for you for an out-of-pocket cost that's very cheap if that's what you're interested in. They are effective in, obviously this is a huge range, right? 50 to 85%. A lot of that depends on your function going in. If you have some function already and you're just trying to make it a little bit better, it'll work better for you. If you have essentially no function, or you've had cancer therapy or radiation or surgery, its efficacy goes down. There's still some benefit to it because it'll help promote blood flow to the penis, even if it doesn't give you an erection, which can just help do things like preserve length and make subsequent procedures easier to do because there's less scar tissue formation. There are a fair number of side effects. Some people tolerate this very well, but a lot of other people will get facial flushing. They'll say, I took it and I got this. My head just felt like it was growing and my eyes were red. And that can happen with some medications more than others. Some have some visual changes with it. If you're on medications for your prostate to help you urinate better, you kind of have to modulate the timing sometimes before we know how you tolerate it. And then if you're on nitrates, which are medications, if you have angina or some chest pain related issues or cardiac disease, you can't take them at the same time because it can, as you've heard, cause an unsafe drop in blood pressure. You've heard a million times on those commercials, right? Next, I'll touch briefly on vacuum devices just so everyone is aware of what's out there. This is basically a device you put around the penis and it helps draw blood into the penis. So it brings the blood in, but if you don't use something to keep it there, it'll just leak back out. So we actually use sort of like a ring, like a tight band that you put around the base of the penis to keep it in there. Now, as you can imagine, this is not the most comfortable device to use. It can be a little bit awkward. If there's any length issues, it can be challenging to use. Putting the band on can be uncomfortable. And the erection isn't very warm. It's sort of this sort of colder type of erection that doesn't feel natural. But for some people with significant health problems who can't undergo procedures or do injection therapy, it's something that you can consider.
Ron, just one thing.
Yeah.
Going back to the oral medications, what would be your recommendation? Because it's so available through the internet, and
Yeah.
what are your recommendations about medical evaluation prior to using it?
So it depends on you. If you are, if you're plugged in with a cardiologist already, and you have stable heart disease, you have normal stress tests, you've done through the whole. If you have a cardiologist, I'm pretty sure you've had a stress test or something at some point. And if you have a clean bill of health, then I'm happy to just prescribe it for you. There are all these online, the sites now, Get Roman, For Hims, all these sort of things, and they're basically a more fancy marketed way of doing what your doctor does and give you generic prescriptions. It might be a little more accessible for certain people. But again, if you come to me and you're young and have no other medical problems, but you haven't been evaluated, then I'll have you evaluated. And if a cardiologist says, nah, you're fine, we did an EKG, everything looks good, we'll move forward.
Right. So you do recommend medical evaluation?
For unless it's like you had a trauma, prostate cancer, but have no other risk factors. If you're a 54-year-old guy, had prostate cancer, but was a clean bill of health otherwise and had great erections beforehand, I probably wouldn't. But pretty much anyone else, if there's no real cause for it, I would have you evaluated, yes.
Question.
Yeah.
Would erectile dysfunction would normally come about with a guy at the age, let's say, 40 and 50? Not necessarily.
It can. There are so many different causes of erectile.
Repeat the question.
Oh, sure. The question was, does it typically come on at around age 40 to 50? Is that accurate? Or
Yeah, I mean that's what I.
yeah. And so again, 40% of men over 40, and that statistic is from this large study that was done in the 90s in New England. So that's the data that we have. Now, coming anecdotally, treating men, I see men in their 30s, but oftentimes they have, we like to loosely say psychogenic erectile dysfunction, where they do have good function, but then there's other issues going on that make it hard for them to perform in the moment. But from a more natural progression of erectile dysfunction. You start seeing it more in your late 30s into your 40s, and really the uptick comes more precipitously in your 50s and 60s, if that helps answer that question. Next would be alprostadil, which is Muse, and I'll talk about this briefly because, I kid you not, our board exam questions about Muse is, why don't we use it? And the answer is because it doesn't work, right? So this doesn't really work. I have to just tell you what's out there because some other physician might. It's a little pellet that you actually have to insert into your urethra, which also just sounds like a not very enjoyable thing to do. And so I don't offer that in my practice, and most urologists don't either. This is something that we do a fair amount, and something that many of you may have heard of or may not have heard of. These are self-injection, which probably sounds like a terribly barbaric thing to do, but in actuality, it's really not that bad, depending on what your goals are. So as we said before, with medications, you need to have that arousal to actually achieve the erection. With injection therapy, you're physically putting in a medication into the penis that will force the blood vessels to open up. So whether or not you're aroused, you will get an erection, okay? And what you have to do is pretty much every time you want to have intercourse, you would stop, go get the medication, you draw it up into a syringe, you clean, you inject it, you wait a few minutes, and it starts to kick in. Obviously, the downsides to this are very clear, right? You're putting a needle into your penis, but just like anything else, you can get used to it. So, do I have patients who are happy with this? I do. But you have to pick the right patient, right? So I have a guy, him and his wife, they have a very scheduled arrangement every Friday at a certain time, after tea and before dinner, and that's their time. And so for them, it's perfect. He goes to the bathroom, gives himself an injection, take their medications, go upstairs, and they're ready to go. And so for him, he's happy. He never wants to move forward. So if that works for you, then great, right?
It's not in the category of spontaneous.
Exactly, right? So, but for him and his wife, that is perfect for them. And so that's why I said, listen, this works for you, you're happy, there's no reason to deviate from this, right? But obviously, that is not spontaneous, right? So when you are randomly in the moment and you have to stop and go downstairs to the refrigerator to get a medication and draw it up into a syringe, then you drop the syringe and then it's all this stuff, right? So it sometimes takes away the luster from it, and I'm sure we all know sometimes your window of opportunity to react is short. And if you have to go downstairs to get the medication, then that's it. The TV is on and game over, right? You're on to the next day. You're back at the Jewish Community Center, right? So we have to try to work on getting more spontaneous. And so for the right patient, this does work very well. But for everyone else, they end up burning out from this. Most people cannot tolerate this long term. Some people do. Most people will move on. They'll either go on to an operation or a procedure, or they'll just throw in the towel. One thing that I will mention that I hear often is, a partner will come in and they'll say, we're in our late 60s now, and this isn't an important part of our life anymore. We have grandkids, and we have this, and we have that. And the way I look at that is, it's not that it's not an important part of your life anymore. It's that when you no longer can do something that you used to be able to do, you will naturally convince yourself that it's not important for you anymore. And I always tell the story that when I was growing up, I'm not very tall now, and I was even shorter and a little chubbier then, and I was not good at football. My friends always wanted to play, and I would say, you know what? I don't like playing football. I'm good. I'm going to stay at home. The reason is not because I didn't like it. It's because I wasn't good at it, and so I didn't want to play. And so the same thing happens with your erectile function. You and your partner, it's still very important to you. It's still something that you want to do, but when you can't necessarily function to the ability that you want, you will convince yourself that it's not an important part of your life anymore. So that's injections. Now, a penile implant is something we'll talk about and I'll show you in more detail. The way to think about a penile implant is the same way you would sort of think about a breast implant or breast reconstruction, except it's not necessarily for your cosmetic enhancement. Think about breast reconstruction in the sense that when a woman unfortunately has to undergo a double mastectomy for breast cancer, they will get a breast reconstruction for a variety of reasons. One, it makes you feel whole, it helps you with function, it helps your clothes fit a certain way, it gives you a sense of self and well-being. And a penile implant is the same thing, okay? I think a lot of people sometimes make light of this and they say, well, that's interesting. Why would you want to do that? I mean, you had this, it doesn't work anymore, and I'm not going to put this in me. But sometimes just knowing that even though I've had prostate cancer and something was taken from me, or my diabetes issue led to this, I still can function the way I did before, even if I'm not using it 10 times a week. That's fine. If I'm using it once a month, I know that I'm ready to go, and I have function, and I have the abilities that I had before. And so that's the way I like to sort of think about it now, as opposed to how many individuals may think about it. It's effective in pretty much everyone that has it placed. Now, what I'm very careful about is picking the right individuals for this, right? If you take an individual who has, diabetic neuropathy and they can't feel like the tips of their fingers, or they have terrible arthritis and they can't squeeze a pump, then this is not the appropriate individual to have one, and so they're going to be dissatisfied. So we always make sure that you have the capabilities to use a device, and if you can't, there are alternatives we can do that don't require any degree of physical exertion or complicated maneuvers. Now, we'll talk, hopefully this will, sort of a long intro into it, but just some background. This device was actually invented by the company that's helped sponsor this program, Boston Scientific, the AMS, in 1974 in Minnesota. So here we have the inflatable cylinders that are inside of the penis, a pump that goes in front of the testicles in the scrotum, and a little reservoir of fluid that goes in your lower belly. Fluid transfers from here into the cylinders to allow you to have an erection. And when you deflate it, all the fluid will come back out and back into the cylinder. Now, this animation makes it seem like you're a bionic human being, and I think on the next slide, which is actually the individual who has one, and forewarning, they picked a young, healthy, thin guy who is relatively well endowed, which is not fair, but that's who they selected for the video for advertising purposes. It's very natural. The most common questions I get: do I have sensation? The answer is yes. Does it change the orgasm? The answer is no. So this is an individual who is squeezing his pump. So as you can see at rest, it looks completely normal. And when you squeeze the pump, it'll allow you to have a completely natural erection. We can usually do the surgery through one little incision up here, or one small incision up here, or occasionally one small incision here and one small incision here. It takes about 1 hour to do, and you go home the following day. That's for your own comfort. The best part is, now we've belabored this point, is you can have intercourse for as long as you want, because it's tied to what you inflate, whether that's 2 minutes or 5 or 30 or whatever you'd like to do. You can maintain it, and when you're done, you simply press the deflate button and you're good to go. A couple questions I always get: how often? Sir?
Dr. 2 slides back, we talked about, right on the bottom, second from the bottom. As an engineer, I find that rather interesting.
Yeah.
How often does that actually happen?
Yeah. So I'm the slide after the next one, I'll talk about the complications and risks for sure.
Okay.
So the benefits, so this is what we call a solution for erectile dysfunction. This isn't masking it, this isn't enhancing it, this will fix it. It's spontaneous. You're not going downstairs to the fridge to get your medication. You're ready to go. Once we teach you how to do it, people are very facile at using it, oftentimes with just one hand. They can last for as long as you want. It's all contained. No one knows you have it. Patients are satisfied. But let's talk about risks, right? So if you go see a surgeon for anything, whether it's an eye surgeon or a urologist or a heart surgeon, and they've told you that they've never had a complication, it's because they either don't operate enough or are lying to you, right? So complications do happen, but they're very rare, and we limit them by how we do things. So The most common complication is mechanical failure, as you probably alluded to or assumed, and infection. They're both still rare. Infection happens in less than 1% of individuals. The risk is higher in uncontrolled diabetic, so I make sure that we check your hemoglobin A1C beforehand. If it's not optimized, I'll make sure you see your endocrinologist or primary care doctor to get that number below 8, because there is data, and it's higher than that, then your infection risk is a bit higher. And then if you have spinal cord injury, smoking, other issues like that can increase your infection risk. Mechanical failure, on average, company tells us that it lasts for about 10 years. That's their median duration before you have mechanical failure. Mechanical failure simply means you need to have the device replaced, which is a very straightforward procedure. In reality, a paper was just published that 55% of men after 20 years still have a functioning implant. So a lot of it just depends on you. I had a guy see me who had an implant in for 34 years. He came to me and it wasn't working, and I said, if it's not bothering you, you can leave it there, but if it bothers you, I'm happy to take it out. He said, Doc, you take it out, you better put a new one in. And so I said, okay, all right, fine, if that's what you want. So we took out a 34-year-old implant, put a new one in, and he's a happy camper. His wife is 20 years younger, so here we are. So those are the major risks of the operation. I will tell you, and this is not to sort of brag about Cooper, but we do more penile implant surgery than anyone in the state of New Jersey. And I tell you that as a sense of pride that we have the same people, the same staff doing it. We partner with the same company. They have the same engineers coming in to help us. It's a very well-oiled machine. And so our rates of infection and complication are far below the regional and national sort of averages, if that helps you feel better. All right. So before we move on to urinary incontinence, any questions? Sir?
Company you partner with? Medtronic?
So Boston Scientific. So there are two companies, and full disclosure, there are two companies that make these devices. I'm not being paid by one of the companies, I promise you. The reason we partner with Boston Scientific is because their devices are antibiotic impregnated. So instead of having to make these fancy antibiotic solutions to prevent you from having an infection, the device itself is coated in the antibiotic, and that can help you prevent infection, and so that's why we use AMS.
Now here's a good one.
Yeah.
Do they give you a protection plan when you buy it?
So protection plan.
Suppose it goes bad within 2 years. Is it billed for free through medical insurance?
So in terms of insurance in general, this is a covered benefit by Medicare, and obviously Medicare sets the guidelines for sort of all commercial insurances, right? So the procedure itself is covered as long as you have a qualifying diagnosis, which essentially everyone does. If you happen to have a mechanical failure of your device, no matter when it is, there is a code for that, and that is also a covered benefit. If you have a separate out-of-pocket issue with your insurance company or deductible, that's separate, but ultimately, whether you have your index operation or you have subsequent operations for repair, they are covered benefits for Medicare.
I have a friend who'd like to know if... I got the question.
So good.
You got the laugh, though.
Yeah.
No, you got the laugh. He was the object of the laugh. Oh, yeah.
Got something from memory?
Yeah.
Is there a cutoff age that the implant would go into?
So no, I tried to be a non-ageist physician. So just because you are of a certain age doesn't preclude you from having an operation, right? Because who am I to tell you that at the age of 92 that you deserve to have a quality sex life. So the individual that I saw and replaced was 84 years old, but he's 84 going on 54. So if you are too unhealthy to have an operation, whether you're 95 or 55, then you obviously can't undergo an operation. but not just age alone.
Two questions. Is there any correlation between prostate size and erectile dysfunction?
That's such an awesome question because we just taught at the medical school, and that is the number one question that I actually got from the medical students, so good question. The question is there a correlation between an enlarged prostate and erectile dysfunction? And the answer is there's emerging data that there is, but no one knows why. And so most likely it's more of a correlative thing in the sense that as you age, your BPH or prostate symptoms go up. As you age, your erectile symptoms go up. So it's more of a correlation rather than causation.
One other question. Cardiologists use this term ejection fraction to determine how well you're functioning. Is there any correlation between that parameter, ejection fraction, and erectile dysfunction?
So the question is basically, ejection fraction is a fancy way of saying how efficient is your heart pumping? How much juice per squeeze is your heart delivering to your body? And does that impact your erectile function? And the answer is there's no necessarily correlation between your ejection fraction itself and your erectile function, but those with a diminished erectile ejection fraction will often have concomitant cardiac disease where they have just poor blood flow, and that can do it, but not a one-to-one relationship.
What are the psychological aspects that will affect erectile dysfunction?
Sure. So the question is, what are the psychological impacts on erectile dysfunction? And right. So that
to it as a
yeah.
symptom of
So
psychiatric disorder or
right.
a treatment for psychiatric disorder.
So I'll give you sort of a multifaceted answer. So if you are on medications for a variety of psychiatric issues, they can certainly cause you to have dysfunction, but that's probably a separate issue than what you're asking. There's plenty of young men who can achieve morning erections and nighttime erections, or erections when they're on their own using whatever stimulus that they're using, but when they're with their partner, they can't perform. And there's a whole variety of sexual dysfunction amongst young people with anxiety and honestly social media related issues, and watching too much pornographic videos and stuff like that can really impact your ability to perform with a partner. Depression, anxiety can certainly lead to erectile dysfunction. Treatments for depression and anxiety, whether you're on a benzodiazepine, can certainly inhibit your ability to have erections. And then the impact of erectile dysfunction on your psychology, if you will, huge amount of depression. I mean, patients who are getting out of their relationships, and not because their partner doesn't value them, it's because they don't value themselves in the relationship anymore. And it depends culturally. When I was in Minnesota, there's a very big Somalian population, and I had plenty of men who had trauma or other issues that said, if I am not able to function, I am not a man, and they would end up leaving their families because they couldn't feel like a real man to support their family. And so just depending on who you are, it can have a huge impact on your psyche overall.
You didn't mention high blood pressure. The relationship between high blood pressure.
Yes, in the same sense as high blood pressure can lead to heart disease and cardiac dysfunction, atherosclerosis, the same thing can happen to the blood vessels in your penis. So the thought, some people, I hear it all the time, well, doc, my blood pressure is high. Shouldn't I have better blood flow? Shouldn't I have better erections? I'm like, well, it doesn't really work that way. The reason is not because you have this influx of blood, it's because your blood vessels have more resistance in the tube. And, so when you explain it that way, then they sort of understand that why high blood pressure doesn't help your erectile function. Sir?
Could you explain the effect of a TURP procedure on prostate cancer and how it would affect you in ED?
Sure. The question is, how does a TURP, which is a transurethral resection of the prostate, which we used to call the old Roto-Rooter procedure, one that Dr. Yorker's probably done millions of in his life, how does that impact your erectile dysfunction and your impact on prostate cancer, correct? So it doesn't have an impact on prostate cancer, except you might be able to uncover underlying prostate cancer by doing it. In the past, because you were using thermal energy as your source to remove the tissue, it could impact the nerves that supply your penis and could impact your erections. That being said, we essentially don't do traditional TURPs anymore, at least statistically. It is still done, but overall we're moving away from doing them. And so now we don't have a lot of impact on it. That being said, one important thing that a TURP can cause is what we call retrograde ejaculation, which means, the ejaculate is a substance that comes out during orgasm. That may actually go back into the bladder after you have a TURP, because it basically will follow the path of least resistance, which will be back into the bladder, right? And so that's a very common finding to have after a TURP.
What is a TURP?
A TURP is that prostate resection procedure that is a very commonly done operation by urologists to help men who have difficulty urinating, whether you're pushing, straining, going too frequently, waking up at night, etc.
Can Tamsulo cause a retrograde?
Yes. So tamsulosin, which is Flomax, which some of us might be on, is a very commonly prescribed medication by urologists that can cause retrograde ejaculation. All right, so we just have a few minutes, and I'll talk about stress incontinence briefly, okay? So stress incontinence is a little bit different. This is basically the involuntary loss of urine when you sneeze, cough, laugh, go from sitting to standing, or really any sort of activity. Now, the difference between this and the erectile dysfunction is that for men, this essentially only happens if you have had treatment for prostate cancer or are a victim of a major trauma or spinal cord injury in your life. So whether you're a diabetic or you have MS or you have cardiac disease, that won't really impact this. If you are leaking urine and you haven't had prostate cancer surgery and or radiation, this is probably not as applicable to you, but we'll go over it anyways. It's very common after prostate cancer surgery. About half of men will have it, but oftentimes it will improve over the course of 6 to 18 months, usually to a point that it's not bothersome enough for you to warrant an intervention, but it's still something to consider. So this is the prostate, this is the bladder, this is the sphincter. This is a muscle that you can contract, that you can control your urinary stream with. This is when you're standing at the urinal and someone by mistake taps you on the back of the shoulder and you stop. That's the muscle that you're squeezing right there. When you remove your prostate, this is one mechanism that you have to keep you dry, called your involuntary sphincter. You sort of lose the ability to really control that very well when you have your prostate removed, or it's not quite as strong as it used to be. So now you're really relying on your pelvic floor and your sphincter. Now obviously, look how close this is to your prostate. So even though surgeons now are very, very, very careful about just taking it off here, if you have a very advanced cancer, you have difficult anatomy, you've had radiation as well, you can compromise your sphincteric function, and then you'll have involuntary loss of urine, okay? Now this has a huge, huge impact on quality of life. The reason is men are not used to leaking urine, okay? Women to some degree, when they go through pregnancy, might have a little bit of leakage, and as women age, the prevalence of mild stress incontinence, which is, again, a little bit of loss of urine with activities or coughing, is relatively sizable compared to men. But men don't leak urine. They have to go frequently, they may have to wake up at night, you may have to run to the bathroom, but more often than not you don't leak. So when you are really leaking a lot of urine and you have no control of it, it really can ruin your life. And people are very upset. They don't leave their home, they don't participate in activities, they won't come to meetings like this because they just want to stay at home, all right? So as we talked about, when you remove the prostate, you have to put the two ends back together and the muscles right there. So somewhere around 10 to 20% of men will have persistent leakage after prostate cancer surgery or radiation. And so essentially, once we get you through a year of trying to rehabilitate you with exercises and things like that, if you're still having bothersome leakage, we'll talk about how we can fix it. I call these treatment with an asterisk because to me this is not treatment. This is just sort of softening the blow, right? Having a planned restroom break or doing physical therapy or a catheter or a clamp or a diaper, that's not treating anything, right? That's putting on a hat when it's sunny, right? That's something different. Now, in terms of how we can fix you, it depends on the degree of leakage you have. If you have somewhat mild leakage, a couple pads a day, overnight you're relatively dry, you can control your stream, but you're still having bothersome leakage. A sling is that a sling, I don't know if you can see the image well, but can you see the image? No. All right. Well, think about a sling as putting your foot on a garden hose and sort of compressing the outflow, giving more resistance to the tube so you don't leak as much. Whereas a sphincter is basically closing off the garden hose completely with a pump. And when you activate that pump, it opens up that closure mechanism and you can urinate normally. Okay? All right. So we'll speed through that. And we're going to buzz through some of this, and I'll take a couple questions about this, and if not, we're going to move on to some of the other speakers we have today. Yes, sir.
Isn't urination a good thing for the body? It cleanses your body. When you say you want to keep, if you don't have leakage, I feel it's a positive thing to urinate and drink water constantly. And why do, for example, myself, I don't have leakage, but I tend to urinate more at night than I do during the daytime.
So the question is, isn't urinating and staying hydrated a good thing? And why do I tend to have problems overnight more than during the day?
Problems. I just
urinate frequently.
I never said problems.
Sorry, frequent urination overnight.
Yeah.
The answer is yes. Hydrating and staying hydrated and urinating are obviously very healthy things for you. And none of these devices stop you from making urine. It just stops you from having the involuntary loss of urine. It gives you the control over when you urinate as opposed to your body urinating for you without your consent.
Well, I'm just going to clarify. Is it a positive thing to urinate, in your opinion, yes or no?
Yeah. The answer is unequivocally yes, because I think we'd all know.
That's why I don't like to take the medication that Harvey Yorker wants to return, Flomax and all that crap. I think it's bad for you.
And so that's why when we come up with a treatment plan for you, it's individualized to you. If taking medications or a procedure doesn't align with your values and your goals, then we don't do that, because this is for your quality of life, which is subjective, right? So we'll always tailor it to whatever you want. Sir.
I have problems urinating, and I'm going for a Uroflow operation next month.
Urolift?
Urolift.
Yeah.
Yes. I just realized Uroflow is the thing that you do when you go to the doctor's office to see how well you're emptying your bladder.
Correct.
Tell me a little bit about the side effects.
So Urolift is a newer procedure that we do that helps sort of open the prostate to make you, help you urinate a little more efficiently. The most common side effects are bleeding for a couple days, pain in the area that makes contact with the bicycle seat for upwards of a week, and some people will have urinary urgency and frequency for a few weeks afterwards.
I take oxybutynin once in a while as a lady. Is that a good medication for this?
So the question is oxybutynin, which is a very commonly used medication for an overactive bladder. I do not use oxybutynin or any anticholinergic medication any individual over the age of 70. There's emerging data that it can help potentiate or exacerbate mental status changes and dementia, and has lots of cross-reactivity with other medications. So There are other medications that are non-anticholinergic that are available that I would put you on.
How do you know the best treatment option for somebody with prostate cancer?
That's very complicated, and so that's why I let my awesome partners who are the cancer specialists who deal with prostate cancer all day, they'll have that very nuanced conversation with you because it depends on a huge variety of factors. It very depends on you and your overall health and things like that. All right, so one more question, and then we'll go on to the speakers.
Follow up this question. There's an article in today's Philadelphia Inquirer about prostate cancer treatment. And as a person who was faced with that issue, I was. It depends on many things. It could be surgery, it could be radiation, it could be watchful waiting. And it depends on your personality and your lifestyle. And basically, the long-term effects are the same, give or take a little bit. You know, it's just whatever you want to do. If you go for radiation, it'll be 44 straight days of going to the doctor and being treated. And surgery is surgery. So, whatever you know.
Exactly, and so depending on your goals and what you're looking for and your age and your overall health, we come up with a plan for you. Well, thank you all very much for your time. I really, really appreciate it.
Stay up here for a minute. Thank you, Doctor. I'm sure everybody found that very informative. Stan, you want to come up? I'd like to present you with a certificate of appreciation as our guest speaker today, and come back and see us for breakfast.
Oh, wow. Thank you very much.
And one more thing, we'd like you to draw our 50-50 winner. David?
Oh, sure.
No?
We have two people here that went through surgery.
Oh, okay.
Earl,
a few minutes each.
Earl Nagelberg and Ray are two people who have gone through surgery in the past. If any of you gentlemen, after the meeting is over, is that all right? Would like to come up and talk to them, please do.
All right. Unfortunately, they need this room after we're done, so we're trying to wrap it up. But anyway, we have our drawing for our 50-50. Doctor, if you would like to draw one. And read us the last three numbers, if you would.
Okay.
Oh, he's got two. One's a loser.
All right. So the last three are 0, 0, 4.
0, 4. Do we have a winner? 0, 4. Last three numbers. Nobody? Somebody must have it. Richie? Bob? No, not Bob. Oh, no. No way. You better send Richie up with it.